Hello, Your Excellencies, ladies and gentlemen, distinguished guests. Thank you all for coming to this panel, which is on design in health. And I'll be talking to our very distinguished panelists in a moment, but I just wanted to let you know that there will be questions that you'll be able to ask later on for all of our panelists, so do please raise your hand when the microphones do come round. There are several people holding the microphones, and I think later on you'll be able to get the report on which this panel is based. It's called the Human-Centered Health System, which is really about transforming healthcare with design. And in a moment we'll be hearing from the person who helped to oversee that study. But first of all, let me introduce our panelists, and I'll start at the far end and work my way in. At the far left of me, to your far right, is Professor Charlotte McArdle. She's Chief Nursing Officer for Northern Ireland, and she's responsible for the professional standards, performance, and leadership in nursing, midwifery, and other allied health professionals. And before that, she held a range of senior nursing posts, including Executive Director of Nursing, Primary Care and Older People in an Integrated Trust. Welcome. Professor Ruwaida Al-Maite is the former Minister of Higher Education and Scientific Research for Jordan. She's also currently a professor at the Jordan University of Science and Technology and is an advisor for health and development for Her Royal Highness Princess Muna Al Hussein. Dr. Donald Berwick is the President Emeritus and Senior Fellow at the Institutes for Healthcare Improvements, which he co-founded and led for 18 years. And he's one of America's leading authorities on healthcare quality and improvement. And in 2010 was appointed Administrator of the Centers for Medicare and Medicaid Services by President Obama. Dr. Dina Al-Thani is the Assistant Professor at the College of Science and Engineering at Hamad bin Khalifa University. Her research areas of interest are inclusive design, designing for e-health, and users evaluation studies. And she has a PhD from Queen Mary University and has taken part in UN panels, including for the UN Commissioner for Human Rights. And Stacey Chang is the Executive Director of the Design Institute for Health at the University of Texas in Austin, a first of its kind institution dedicated to applying design approaches to solving systematic healthcare challenges. And the Institute considers a huge range of and broad range of topics, from design of health products to the functionality of the health ecosystem. And last but by no means least is Aaron Sklar, who is the co-founder of Prescribed Design, but throughout his career, Aaron has led innovation teams through a human-centered design process focused on improving people's quality of life and wellness. He spent several years in health tech startups and 14 years at IDEO, an award-winning global design and innovation firm where he managed projects for more than 50 international organizations. Before we get going on the questions, I'd like to ask Aaron, who's going to make a presentation on this sort of topic, to kick us off. Welcome. Give him a round of applause, please. Thank you.
Thank you. Your Excellencies, ladies and gentlemen, it's an honor to be here to represent our design community. First, I'd like to take a moment and acknowledge our team who have spent the last year working on this report. Get the screen going. There we go. Of course, we have our panel here of superstars, but also in the audience, we have several members of the project team. And this has been a labor of love of bringing this conversation of design and healthcare to this forum at WISH. So the whole experience at WISH, what we're doing this week and surrounding it, has been celebrating the innovative solutions. So solutions of great ideas in eye care and viral hepatitis. One thing that's unique about this conversation that we're having right now is, rather than focusing on solutions, we're focusing on a a method of how to consistently get more and more types of innovative solutions, and that method is human-centered design. The type of approaches that we document in the report can be applied to any of the forum topics here at WISH, or really any type of healthcare challenge, from clinical innovation to workflow innovation, service design, even innovation in patient engagement. So when we put that all together, what we're up to is transforming healthcare. And what we're up to building, we have this big audacious goal of building a human-centered health system. So let's start with a quick glimpse into the designer's mindset. This picture was taken outside of a hospital, and I know it's huge on the screen, but in case you can't read the writing, I'll read it out to you. Ask for a biopsy for peace of mind. And so this is just discarded out in the street, and just looking at this, all of us can read that and make certain assumptions and inferences. This was probably written by a patient. This patient is probably stressed, has some anxiety and concerns, and just had a consultation. There's a lot going on that we can actually just deduce from this little snippet. The reason I'm sharing it in this context is we believe behind every healthcare interaction, there is a human story. And the designer's mindset is to discover what that human story is in each case and use that as the impetus for innovative solutions. Here's another glimpse from inside of a hospital, and I suspect the people who worked in this department could teach us a lot about data security. So again, this is the kind of detail that designers pay attention to, how things actually happen in the real world, in day-to-day life, not just what's written on the procedural manual. When you actually see what's going on in the real context, again, that's our source for inspiration for innovative solutions. So design accelerates innovation. And again, I just want to reiterate that when we talk about design, we're talking about the whole range of healthcare solutions: the clinical side, workflow side, service design, and patient engagement. I won't read out the quote to you, but really, if you only take away two key words about design in this, from today's conversation, they're empathy and prototyping. A common misperception, and actually we were just talking about it backstage with the panel, a common misperception is that designers are here to make things look pretty. And yes, that is often part of it, but there's so much more to what the experiences that we're designing, so much more to healthcare beyond just looking pretty. When we're talking, there's all of these different professional skill sets that make up a design team. And for our goal of transforming healthcare, we need all of these different design disciplines. I think you can read them, but there's things like human factors, which is understanding the brain and memory and attention. There's industrial design, understanding how things are manufactured and built. There's visual and graphic design, content design. How do you tell a story? What's the tone of voice? All of that together is what we need to build that human-centered health system. Every design team has their own sort of way of describing the process that they go through. For our report, we used, as an example, the Double Diamond Framework, which was created by the British Design Council. And there's a lot of great things we love about it, and it's just so clean and clear. It walks you through the 4 different stages: discover, define, develop, deliver. And I like to think of that, again, that first diamond as an iterative step of empathy, and that second diamond of the iterative step of prototyping. And every design project goes through this iterative process. And this is what we use to ensure that consistently coming up with those types of innovative solutions based on the real experiences and motivations and behaviors of real people. So putting that all together, a multidisciplinary design team using the design process is what gets us to that human-centered health system. So our report, we go into detail in 3 different ways of engaging people on the front line. We've already covered enough, I would say, professional design, professional designers' way of engaging with patients and clinicians. Co-design takes it a step further, and treating patients and clinicians and other stakeholders as equal partners in the design process. Rather than just a source of input, it's a collaborative experience that they're brought into the team to come up with solutions together. Design thinking is a much more distributed approach to engaging people. This is imagining a whole workforce thinking and being trained in the practices of empathy and prototyping, and using that in their everyday work. Each of these approaches brings their own unique value and can be used at the right time in a project. So our report covers case studies from around the world that use design to reach their innovative solutions. I won't go through all of them. They're all sort of detailed in the report, but just to highlight a few. In India, we highlight the Aravind Eye Care system. They did an amazing job of so many different pieces of design. They redesigned a product, their intraocular lens. They redesigned their roles and their workflow, which we call service design. They even redesigned their clinics, which we would call space design. And they went through a whole design process with each of the different pieces of their business. In the UK, we highlight a digital tool that helps pediatricians choose the right dosage for pharmaceuticals. And here in Doha, we highlight a product design experience where new laparoscopic surgical tools were created. The most exciting part of our report is our action plan of recommendations, and I'll go through them now. So we bucket them into 3 big categories, and so there's 9 recommendations in the report, but they come down to these sort of 3 statements I'll read out to you. All projects should involve input from both patients and providers. On the surface, that sounds obvious, but it's actually a pretty bold thing to say, yes, for every healthcare innovation we're going to do, we're going to make sure we get the right input from those people. The second one, all health system employees should receive training in design thinking. Again, expanding the force of people who are thinking in this way and coming up with solutions. The third recommendation is all healthcare leaders should know when and how to involve professional design expertise. So again, these actions may initially seem bold, but they are becoming more and more mainstream in other industries, and they're becoming more and more mainstream here in healthcare. And our recommendations are a big contributing factor to what we're all here to do, transforming healthcare and accelerating innovation. On behalf of our entire forum team, thank you.
Thank you very much for that, Aaron. Do come and take your seat. I'd like to start off, Stacey, by asking you first. I mean, you've worked in a lot of organizations over a number of years. When you, as Aaron was sort of making his presentation there, the sort of plan of action, embedding this idea of design at the heart of organizations, when you've tried to do that in the places you've worked, what have been the problems or the pushbacks that you've come across in trying to engender that kind of culture and dynamic?
It's a good question to begin with because the problems are many. But I might actually invoke a statement that actually one of Don's colleagues is quite keen to often say, which is that every system is perfectly designed to get the results it gets. And what that means is that if you're trying to make change, the systems and organizations that are trying to make that change are actually not prepared to do so. I think a very close corollary is that every system fears trying to get what something it doesn't know how to get, right? In other words, organizations fear uncertainty And that's very much true for healthcare as well. As we try to make change in light of new diseases and new approaches to treating them, to the new epidemics and the problems that we face, a lot of the healthcare organizations and systems I've been privy to are reluctant to change. They adhere to legacy, and it's because it feels safe and comfortable, sometimes in spite of the fact that the change that they know they need to make is actually for the better. And I find that usually the way that that gets overcome is by just a little bit of courage, sometimes from enlightened leadership, sometimes from frontline staff. Design as an approach to solving complex problems is neither linear nor predictable, and so there's a necessity for tolerance of uncertainty, and it requires a bit of courage to overcome that. I think the other challenge that I see quite consistently in systems is a little bit more of a modern phenomenon. So in the last 2 decades, we've anchored very much so on this notion of evidence-based medicine, right? And it's this idea that good clinical research, good clinical trials and quality evidence can define how you practice medicine. And I'm not here to argue against it because it has been tremendously useful in organizing the way we systematically address therapies and disease. But I think one of the problems is that we've become a little bit complacent, that we've put too much faith in science. And I will make a claim that medicine or healthcare is very much an art and a science. And one of the things that we've lost sight of is the primacy of the patient-provider relationship, the relationship that happens between someone who needs care and someone who can provide care. And uniquely, design is very, very good at understanding the human motivations within a system and helping elevate that and return that to the center of medicine. It's really in those interpersonal relationships that care and value gets delivered in healthcare systems. So design just happens to be very good at that, and one of the most useful tools I've ever encountered for actually overcoming those things that are actually more qualitative in nature than quantitative.
Okay. Dr. Berwick, can I come to you next? Because at the heart of this report is your vision of a person-centered health system. What are the next key steps, do you think, in order to educate healthcare staff on the importance of incorporating this sort of patient-centered design into healthcare?
I think the first step is to let go of some previous assumptions, feelings, attitudes. The two that concern me the most that are very prevalent are either the belief that excellence will come from heroism, that if we just try harder, we'll have success. And that's especially incorporated into the self-image of clinicians. So physicians are trained to think that it's my patient, my job, I've got to do it. It won't work. The second is the opposite, which is external accountability, that if someone else presses you hard enough and makes you want to do it through measurement or incentives or payment, you'll get it done. Both of those violate the basic principle of the panel, which is no, it's design. Change the workforce, put a new group in, you'll get the same results, the same design, more or less. And letting go of that stuff is very, very difficult to shift your attitude to thinking it is design. We feel that you're trapped, and until you participate in the change of design, you won't have any different performance. There are sciences of design, and you have to be careful about asking that medical education change add stuff, but there really is well-developed science here, and human factors design, the principles of design that you've studied, I know we'll hear more about. I think we should be at least make people aware that there's science here. And that the current designs are very poor. You fail often in healthcare, parts per 10. The general failure rate in healthcare is parts per 10. And that's because the designs are so frail. So maybe being aware of the need. And then the co-design piece, the voice of the patient or family or community matters a ton. The more people speak up, the better the designs get right away. And but I think believing is possible. I learned this out. One quick thing. Here's what opened my eyes. There was a little story I read in a book. Have you ever left your card in an ATM machine?
All too often.
Huh? All too often. It's possible to eliminate that mistake, not by trying harder, not by posting a post-it note, not by yelling at people, not by a training program. Change the order of the tasks. So you have to take your card before you get your money, because nobody leaves the money. Changing the order of the task eliminates that error. It's just embedded in the design. It's the same for almost everything we do.
Very interesting. Well, Dina, I'd like to come to you next because you're a firm advocate about more accessible design. Why do you think it is vital, if we are to sort of take the next steps, as Don was sort of saying, or at least begin to include service users in design and evaluating that process?
I come from a background of inclusive design. All I do is design for people with disability. And all I do is involving people to design a product. So this is the main message I want to deliver here. You cannot design a product without involving the target group. Undoubtedly, nowadays, the advancement in technology has been a blessing for people with disability, in particular people with visual impairment. Why? Because the technology developed were by them and for them. That's why they knew the need, and they developed something that is right for them. So from here, I would like to basically say that if we guarantee that the patients, caregiver, medical staff are integrated in the process of design, we will get better services, we will get better workforce, and so. And from here, it's just, I'm so glad to be here to get this message across and be with the Routable Forum member to discuss the issue into how can we get this message across to healthcare and to the processes in healthcare.
Thank you very much, Dina. Professor Ruwaida, can you comment on the sort of the human-centered health system action plan that's proposed in this report, and in particular how you think it might complement the World Health Organization's Sustainable Development Goals? I mean, how do the two fit?
Yeah, thank you so much. I think when I started, I told Aaron, when I started reading actually the report, I just clicked to my mind, the Sustainable Development Goals and some other important also initiatives and resolutions, for healthcare in the world and, strengthening the healthcare system. So the uniqueness actually of like you said, Aaron, that the uniqueness of the proposed action plan lies in its focus on the human-centered approach. And it fits very well actually with the 17 SDGs, the Sustainable Development Goals, which is also the power of the goals are rooted in their power that they are all people-centered and planet-sensitive. So it's both, and this is, I think, very important. I read actually many articles and evidences saying that, we have also to change our, way of thinking for the healthcare because the future will be different. Mostly we will concentrate on the primary healthcare. And last month, you all know that, the Astana Declaration about the primary healthcare actually just been, issued last month. And all politicians actually, they are all committed to primary healthcare. And the notion is that, we will see more people using the primary healthcare, and hospitals will be something like only for very acute patients and like small ICUs. So we have to change, and we have to know how we're going to link the people as well as the community. We have also the report of the NCDs, which is also, we have the High Commission on NCDs, and in the United Nations, actually, September this year, also the political leaders also, they agreed on it, and they emphasized the importance of active engagement of people and community in all processes of designing for health as well as of planning in order to accelerate also the attainment of the SDGs. There are some other important, actually, notions. I don't want to go one by one, but it fits in all of them. They fit actually very well within the three categories. And I'm happy, to share it with you all. We have also the WHO 13th Global Program of Work, which emphasizes the importance of innovation, of research, of evidence-based, and also the involvement of people and, having people in the heart of everything that we do, because the Millennium Development Goals, the 8 goals in the past, Actually, one of their weaknesses, actually, it was, about, leaving people behind. The new SDGs is no people will be, left behind. So this is very important. The other thing also, we have the global strategy on human resources for health. And that's very important because we are not talking about, when we talk about people, I mean the patients and the healthcare providers. We have also to look from different angles for the education of the healthcare providers also, because we have to redesign and come up with the new models of education and teaching for the healthcare providers in order to also know what do we mean by design for health.
Okay.
We don't want this part to be only for architects or artists or whatever.
Sure.
So I think this is very important to start working in the interprofessional education, not only for health workforce, but also with others.
Okay.
The other thing also, in addition to Astana, we have also the new report that will be launched tomorrow.
Okay.
With the nursing now. This is the nursing and universal health coverage, and this is important also talking about nurses also leading the healthcare system within a new, design for health and to be part of it for now and the future.
Okay, thank you very much. Speaking of nursing, straight on to you, Professor McArdle. When we talk about this sort of issue, and Dina sort of, raised it, of putting people at the center of, design within the sort of healthcare system. I mean, from where you've worked, how do you do that practically? What are the kind of ideas that you can sort of practically implement, co-design, and also feedback processes that put patients at the center of care?
That's a very important question, because we can talk for a long time about how in theory we do these things, but implementation is really key. And as you've heard, it isn't easy. It seems like the right thing to do, but isn't always easy, because it requires us as a healthcare system to work in a different way, to change the relationship that we have with the people who we provide care for. And that means that we need to become more facilitators of people taking decisions about their own care, instead of the paternalistic model that we've had, or as Dawn has referred to, the heroism type model. So that means we have to work with patients in a real partnership. And again, that's easy to say, but not always as easy to do. And it's about valuing the contribution that everybody makes, so that everybody has a voice around the table. And it's important that that voice is there from the very start of the co-design process, that we don't go to people with one we have already thought about or half designed or think is getting us to the right outcome. We need to start at the very beginning. And everybody has an equal say, the person with lived experience in particular, clinicians of all colours, managers, scientists, etc. Everybody's view is important. And that means that we have to then recognise the contribution that people have made. And for people with lived experience, that sometimes can simply mean thank you, but it can also mean providing them with an opportunity. For example, someone who's recovering from mental health illness can use these opportunities to be involved in co-design with system leaders as part of their recovery journey back to normality. So there are really important opportunities in this to help people along their way. But we have to make it easy for them, and at the moment it isn't always easy. And there are very practical steps that we can take to do that. Remembering that many of these people with lived experience have some kind of health problem or illness, so we have to change how we work. We can't have meetings at 8:30 in the morning in the boardroom that last all day. Those people who are coming to our table can't work in that way. We need neutral venues out of the boardroom and much shorter meetings to enable people to engage. And we need to be very careful about the language that we use, both in terms of technical language of healthcare, but also understanding and being able to talk with people in a language that they clearly understand. And we have to accept, I think, as system leaders, that this is a different way of working. This is the new tomorrow, and at the moment it's not how we do things around here. We need to make it the way we do things around here. It takes time, and we've already heard it takes courage. It takes us to be open and honest, and to recognise that it might take a much windier road to get to the outcome, but there's one thing for sure, and that is that we'll get to a much better outcome. And one very small example of that is a group of secondary school boys have worked with their school nurse and the principal of the school to redesign the job description of the school nurse so that it better meets their needs. So they were asking for her to be much more of a coach, to work with them on mental health issues, as well as provide the technical care. And so together they co-designed a new job description, and now that nurse is working to support her pupils.
That's really interesting. Thank you. A lot of food for thought there. Yeah. Thank you. I'm going to open the floor up to questions. There are roving mics around, so if you want me to call you up, do hold your hand up, and then do stand up and ask a question if it's for a specific member of the panel or if it is for everybody. So we've already got some hands up. There's that lady there in the, go ahead. And do say who you are.
Good afternoon. I'm Nawal Khattabi, Risk Management and Patient Safety Director in Primary Healthcare Corporation with interest in human factors and system safety. My question is for Aaron. You have been working in IDEO, I think, for a decade, and IDEO is known for the design organization in Silicon Valley. So I was wondering, from your experience in IDEO to healthcare, what is different in serving the industry of healthcare? What are the opportunities and what are the challenges? What do you see different? My second question is, how do we, it is for the whole panel, how do we consider the dynamic nature of healthcare system? So many literature has highlighted the healthcare as a complex adaptive system. So how do you consider the dynamic nature in the design?
Go ahead, Aaron.
Yeah, thank you. What a great question. I'll invite Stacy to comment on it as well. Stacy and I both worked together at IDEO many years ago. So the question is, IDEO as a design consultancy really promotes human-centered design principles across many different industries. And the question is, what's unique about working in healthcare and applying that kind of conversation in the healthcare arena? And I mean, there's two answers, and one answer is that the actual process is the same, like the steps that the team goes through, actually even how the team is made up is really the same. There's a lot of interchanging of people between different projects that cross industries. So that's one side of the answer. The other side is that there is always, within healthcare, there, especially in the United States, there's a level of complexity of how the business works. And sort of, particularly when we're thinking about when we're connecting with things like the electronic medical record and sort of the big player, the different monopolies that are at play in different pieces of the healthcare system. So there's a bit of sort of expertise that needs to be developed and fluency. And I would say not so much in achieving the innovative solutions, but more in building the right relationships and building credibility and trust with the right partners.
Stacy?
I'll definitely add to that. I think there's one unique distinction between the work we used to do at IDEO and the work, certainly that I do now, I know that Aaron does as well, embedded in healthcare systems. And that is, when you're a consultant, you're asked to work often on the edges of the dysfunction. You have a client who comes to you with a potential opportunity to usually increase revenue in the business they're in, and you end up writing an interesting fairy tale and then hoping that it gets implemented in that unique intervention. I think the work that we do now is at the heart of the healthcare system. We never had an opportunity at IDEO to actually work at the heart of the dysfunction in the healthcare systems. And I'll leap into the second question that you had because these are related. There are no longer any simple questions in healthcare. Every one of the forums, every one of the presentations, every one of the challenges that have been highlighted today and I'm sure tomorrow are complex system issues by nature. Right? And if you consider for a moment that the very nature of disease has changed in the course of the last generation or two, right? I think someone in the data and AI panel, I think Professor Sheikh was the one who said, hospitals and health systems that came before us were designed really for interventions on mass infections or the casualties of war. They were really meant to address acute trauma and infection. The nature of disease that we face now globally is fundamentally very different. Diabetes, hypertension, obesity, those are not things that get fixed in a clinic. They're longitudinal. You live and manage that disease over time instead of living in spite of it, right? And so the kind of care we have to provide now is much more pervasive. It's longitudinal. It's about behavior change. It's about social determinants, about many other things other than the quality of your medical care, and has to consider a lot of those things. In the US, we suffer tremendously from loneliness, suicide, and depression. Those are also things that are not fixed in the clinic. And so they require very human intervention that's very different than the kind of technical, medicine-based, technology-based interventions that we've been clinging to for so long. And I think those are, in nature, the differences in those problems. And so these problems are systemic in nature, right? And systems, by their nature, are indeterminate. You cannot perfectly prescribe a solution, put it in the system, and expect it to work. Because systems consist of entities that have sometimes competing interests. They don't act the way you expect them to. At their boundary conditions emerge all sorts of properties and behaviors that you cannot perfectly predict. And so design as applied to systems is actually a very different application of design. It's about provoking a system, seeing how it responds, and then tuning the intervention again and again and again, and learning, failing, because we certainly will, but then learning from that failure and continuing to tune it. That is a very different kind of design, one that I think is becoming the domain of the work that we do in healthcare.
Thank you very much indeed. Don, I mean, you've had a pretty unique perspective about the dynamism of the healthcare system. Do you want to give us your thoughts?
I love the question. Just a couple of quick thoughts. One is you have to design for the dynamism. The designs we've inherited are static. This is the way we do it. And I don't know how many times I've heard that as a patient. I walk in, ask a question, no, we do it this way, not that way. But you can imagine designs that are inherently adaptive, and that's, I think, the core answer to the question asked. It means that you have to embed a level of curiosity in the system, like you were talking about, where inquiry is embedded in the process. When my wife was pregnant with our second child, who turned out to be Dan, I remember going into the into the consultation room, the surgery with the obstetrician. Paul Goldstein was his name, and we went through the visit, and then the visit ended. He said, "I know you two were very busy, but would you spend one more minute with me?" Said Paul. He said, "Today, Ann, Don, the way I examined you, Ann, the way I talked to you, the way my staff greeted you, the way it all went, was there anything that from your point of view, could have been better?" That's how he ended the consultation. I think that may be how he ends every consultation. So as the world changes, he's going to get different answers, and he can adapt to that. And that embedded curiosity is key, I think, to the kind of design thinking we're talking about.
Charlotte, do you want to go ahead, Rowena?
Yes. And I would like also to add that, in addition to the NCDs, which is, huge challenges, as well as the mental health and, the increasing number of suicide and, depression cases, as well as actually the road injuries and the road safety, which is very important all over the world. I think that we need, the summary is that business as usual is no longer an option, because things are getting, I think, worse at, the level of health problems in the world. We are having more people with NCDs. We have, the aging population with not enough, actually, people-centered, healthcare services for them. So I think we need to change the narrative. We need also to concentrate heavily to invest in the people-centered approach and services. This is very important because I think if we are not taking, that angle of the design, which is, I think, very important, and luckily, we teach our students about, this important issue. I think also there should be more commitment from the politicians as well as, the leaders in healthcare sector to emphasize, the design and to marry. It is like a marriage relationship that, you cannot just, give up between the healthcare, the social determinants of health, as well as, the design. This is a challenge that we have to work it very well.
I'll come on to that last point about policymakers and politicians and, their importance in getting this idea through to them. Charlotte, do you want to comment?
So I've spent quite a bit of time developing guidance on how to co-produce, which are government guidelines in Northern Ireland, where I come from. And as part of that, I co-designed those guidance with 30 people from a variety of backgrounds, half of them people with lived experience. And they told me over and over again they are fed up giving healthcare feedback. What they want to see is change. And this type of approach enables that change to happen. And what we need to do is to continue to grow the number of people who work with us and are involved in this co-design process, so that we're building networks into communities, so those communities can give us feedback, and so that they can take the change and make it real for those communities, so that we have a consistent dialogue with people rather than the reactive care that we have at the moment.
Thank you very much indeed. There's a question up from there in the balcony.
Hi. Thank you very much for spotting me. I think this is the third session at this Qatar event where I've tried to get the chairman's attention from the back. As a wheelchair user, this is the easiest place to be, but it's the most invisible place to be.
Well, we're glad we spotted you.
Well done. Thank you. My name is Robert Johnston. I'm on the board of a group called the International Foundation for Integrated Care. And I'm an active self-manager of my own condition. I've lived for more than 60 years with rheumatoid arthritis. I've learned a lot of lessons in that time. I've had a lot of good opportunities and support and training. And I believe all patients should have that opportunity. And when you've done that, when you've learned about self-managing your own condition, consulting the doctor or the nurse as specific experts when you need them, listening to their advice, valuing their advice, but also expecting them to value your feedback and your own experience, not only do you become a more efficient manager of your own care, but you can help other patients with chronic conditions. And you can help reform the whole health system to make it more efficient. Why is there no patient up on that platform?
Good question.
There should have been.
Yeah.
You know, we have this saying, nothing about us without us. The nicest people in the world, which you may well be, you indeed probably are, it's not the same as letting me be there and be part of the process. And people talk about participatory systems and participatory healthcare, but I like the phrase emancipatory. Because once you start getting involved in creating processes, helping systems be better, helping things for people, you grow as a person, and you can help the system to grow, to integrate more people. So next time I'd like to be on the platform.
Absolutely, you will be. Give them a round of applause. Thank you. I'd just like to ask a question, actually. Are you saying in that last point, then, that in some ways, I mean, being part of the design process, for want of a better word, this consultation process, is also part therapeutic as well?
Absolutely. You know, we keep having these discussions about we don't have enough doctors, we don't have enough nurses, whatever. What we want is everybody in the population to be managing their own care to some degree. You know, your adolescent male will still drink too much and do all the wrong things, but as you grow, you should become a much more active manager. I bet everybody in this audience, if they or their family became sick, would want to be an active participant in that process. And it's not just in medical audiences where that's the case. You know, I've been in scientific audiences, I've been in design audiences. You know, it's not the doctor expert, the patient idiot, you know, either doing what they're told or not doing what they're told. We all want to be involved to varying degrees, and we can if the facilities and the situation is created to allow that to happen. People ask questions about healthcare being complex, always changing. You build in the iterative process. You all grow and learn together. You try different things out. And then you will grow to something which is appropriate for that period of time, but will then have to change later for something that's more appropriate later on.
Excellent, thank you. Well, that's a pretty powerful and eloquent exponent of, you know, people-centered care, isn't it? I want to go around the whole panel to sort of get your reaction, starting with you, Aaron.
My first reaction was to hit my forehead. Yeah, thank you so much for pointing that out. That was an obvious lack of inclusion, and it's something that I've had experience personally at conferences and at other kind of venues, and certainly in design teams, to have patients be both part of the conversation. So thank you for bringing that in, and that was definitely an oversight. The one thing I'd like to add is there's a whole conversation, sort of what you're highlighting of there's a label, I don't know if this is how international this label is, of engaged patients that's called e-patients. And there's a whole community of e-patients who together go to conferences and speak out and make sure that their voice is heard. Also within our prescribed design community, we've coined a term called D-patients, which are patients who design. And just like you're describing, designing their own interventions and sort of their own solutions for their own care. And we, on our website, are celebrating those stories as well.
Yeah, I'll reinforce a little bit of what Aaron said here is, in the end, we are all patients. In fact, healthcare is one of the very few sort of universal experiences that all of humanity shares. We all are born, we all die, somewhere in between, we all get sick. And so we should all have a point of view on what we want our care to look like. And as we move forward, I welcome you on this stage, though. It's not an excuse for not to have a patient represented up here. But as I was mentioned before, the nature of disease has changed, and actually the expertise is no longer sequestered in the professional clinician, right? The reasons I don't take my drugs for diabetes or for hypertension, or the reason I don't lose weight, even though I know it's better for me, are not reasons that have clinical rationale. They are all about the circumstances of my life, of the community I live in, the work I do, the circumstances I have to contend with. And so we are as much experts as patients as our clinician brethren are. And in what you invoked in particular, I think is important, which is we have to design health systems that are no longer static, right? You know, to presume that the models that we have now will even be relevant in 5 years, never mind 2, right, is actually just disingenuous. What we have to design then, and what we have to create policies for, are learning health systems. It's a notion that gets bandied about in academics all the time, is this idea that health systems that are continuous learning. But I think they often miss a point, which is they often confine that to learning as prescribed by the experts. Whereas, in my view, the learning has to be invoked by those who are most affected by the healthcare as well, who are the patients.
Okay, thank you. Dina?
Well, I totally agree with your point. We should have a patient representative, a caregiver representative within the forum. And I totally agree with you that in health, the involvement of patients to get input is the most centric and fundamental aspect that we should consider, because that's the point of view that healthcare need to service upon. And another thing that you point out is the process is iterative. So we do something, then we get feedback, and we keep changing. I don't know how much visible this in healthcare. I myself have some projects in healthcare, and I find iterative design approaches quite hard to do because when we apply for a clinical trial, we go into a process of ethical approval, governance, and so on. And then we wanted to do another iteration, and we get to the same process again. So how visible is this in healthcare? I'm not sure. Maybe people in healthcare can answer this question better.
Great, thank you. Don, I mean, just as a layperson, I mean, listening to that gentleman, one's also just struck by just the sheer amount of expertise that's and experience that's, you know, there of people who are the sort of, you know, the patients, the whatever, you know, there's an enormous resource there.
Expertise and passion. Did you hear the energy? I mean, the amount he's willing to bring to this. And we really blew it not having a patient up here. What can I say? This is a hard discipline. 3 quick responses, other reactions. One is this potential of self-management. I'm sorry, I missed your first name, sir.
Sorry. Robert.
That Robert was talking about. It's immense. We're doing a lot of discussion of machine learning and artificial intelligence. I'm a big fan, but I'll tell you, anything we're doing in the technology space that gives the patient and family and community self-management opportunities, I'm sure it's improvement. I'm really impressed. Second is, in Robert's conversation, he debunks a myth. It's another thing we have to let go to, and that is that if patients get controlled, demand will rise. Not true, not true. The fear, because we have inadequate systems and everyone feels so stressed, is that once we give power to patients and families, what's called emancipating, care, emancipative care, that demand will be overwhelming. That's not what the literature shows. The more people get involved in decision-making about their own care and control, actually demand falls, costs fall, and outcomes improve. It's a win-win. But that's a change of mentality. The third change of mentality is the change of control that we're talking about. I'll give you 3 examples. This is my own personal interpretations. We should not have any restriction on visiting in hospitals. End of story. What gives a hospital a right to tell me that my wife can't see me? Where did we ever think that was possible? Self-medication. I take medications at home. If I go in the hospital, why take my bottle away from me and put it in my mouth? Why don't you let me bring my meds and take them? I'm going to go back home and take them. A third is who owns the medical record? I'll tell you, I do. The patient does. And I don't care what the habits are or what the history is. There's only one right answer to that question. But that's a very disruptive set of ideas, and that's only the beginning of the list.
Okay, thanks very much. Dr. Ruwaida.
Thank you. I think that, like you said, I think patients and people and community, they all should be at the driver's seat also. And how far we're going, the journey, they have to start from the beginning, from the piloting, till the end, for the evaluation phase. I think this is very important. I always said that, in the healthcare sector and services, there are many, less traveled, roads. And, I think the design and the IT and the technology, though, we have much improvement, but still it's not like, universal improvement. We have to invest more in youngsters also. As a creator, of new service, models, we have to change our language in medicine also. Instead of saying, to redesign the medical record or the healthcare, let's say, the service, because, the end users are, the community as well as the people. I think there are many things, terminology, that we have to prepare our homework for the future. Otherwise, we will keep having, more complex and chronic conditions, and then, it will be a chaos for the future. We have to be really prepared for the future.
Thank you. Charlotte.
Thank you, Robert, for that challenge. And of course, you are totally right. Of course, you should be on this platform with us. But I think I'd like to take that a step further and say if we're really going to work in true partnership, then there should be 2 or 3 people here with lived experience and 2 or 3 healthcare leaders. And how different would that look? And what message would that send to how serious healthcare is about working in real partnership? And that gives 3 very different perspectives on what it's like to be a person who has a condition for the length of time that you and others have had. Again, feedback from people who I've spoken to in this field say they often get tired being the go-to person, and so we need to build a network of peer support and experts like you to help others to develop into that role where they too can share platforms with others, and so it becomes less burdensome on everyone. And I think the important point here is that peer support is so important. We need to build capacity and capability in all of our people to be able to do this kind of work.
Thank you very much. A question from there, yeah.
Hi, I'm Shuaib Amini. I'm Head of Healthcare Informatics at Aspetar Sports Medicine Hospital here in Qatar. Human-centered design, my understanding is that involving the stakeholders in design. How do you tackle the conflict of interest, diverse vision when it comes to design, as you involve many stakeholders? Will the ultimate decision be with the designer at the end?
Very good question. I'll throw that to you guys first. You go, Aaron, and then Stacey.
Yeah, that's
more power in your hands. More power in your hands, maybe.
Yeah, and that's an interesting question. And there's sort of that model of taking all of this different information together. How do we then make that decision of what's the right path forward? What's going to be the most sustainable solution for whether it's for the business, for the patients, for the overall system? Again, I see that as the role of a designer to be able, not the role, but that's actually the strength of a designer is to take all of those different viewpoints and synthesize them and say recognize from all of the constraints that we're incorporating, here's what the best path forward is. Because as you say, you could ask the seven of us here on the stage, and we might all have different opinions on the same topic and different paths forward. But there's a truth in each person's point of view, and there's a strength that designers bring to that conversation, which is synthesis.
Stacey.
I'll answer it in the order that you asked, because I think that's important. I actually inherently believe there is no conflict of interest in healthcare systems. There are two human parties in the system, one who wants care and one who can provide care. Yeah, there's a lot of other things at play, certainly the viability of the business, the finance, all the pieces that underpin that. But every physician I know joined the field because they wanted to do good on behalf of their fellow human. Every patient I know who's in the system wants to get better, and they want to do that quickly, efficiently, and with as little pain as possible. Now, there's alignment in the system towards those aims, right? And there are a lot of other things that we have to contend with, like the finance and the policy and the risk and the legal and all those other things. But fundamentally, this is a very human system put together for the benefit of mankind. And so I don't actually think there's conflict per se at the very highest level. There is definitely conflict in the execution of that model, and that's much of the things that distract us, I think, across systems internationally. The other thing I would say is that the power of the designer is not to prescribe how the system operates. The power of the designers is about revealing opportunities for that alignment to happen. Designers don't view themselves as authorities, but rather as enablers, right? So the role of the designer is not to prescribe how people interact, but actually to enable them. And I think that's actually the biggest distinction in understanding the role that design plays.
Okay, Don, very quickly, because I'm going to race through some more questions. But go ahead. You were going to say something.
There's a technical idea that I ran across that I'll share. It's called mass customization. It's a really powerful idea, which is if the design simplifies everything possible, everything that should be standard is standard, then you can reserve energy for adaptation to every single individual as a human being. There's a really strong relationship between simplification and the release of energy to customize to every individual. That's the resolution of, at least some of the resolution of that question.
All right, we're going to try and race through more questions from the, there's someone there first, and then at the back, number 2 first. Go ahead, this lady.
I'm Linda Gask.
I'll come to you next.
Oh, sorry.
No, you go ahead, and then I'll come to that gentleman
Right.
next.
I'm Linda Gask. I'm a psychiatrist. I'm aware that mental health care is ahead, I think, in service user involvement. I say this because as a psychiatrist, last year I spent 2 weeks in hospital with a serious physical health problem. And I had such appalling care that at the end of that care, I wrote a letter to the chief executive of the organisation who said, well, do you want to make a complaint? And I said, no, I'd like to know that the system's going to change. And so he took my letter, and I never heard anything again. And it seems to me that we need to break down. We've mentioned that you're all patients, but how many of you ever talk about your patient experience? How much of that is ever used to really challenge the involvement of people with lived experience in healthcare systems? I do talk about my patient experience, and I think that those of us who've been in the system and then experience it, I'm just suggesting sometimes we can be really quite disruptive, and sometimes people don't like that in healthcare, but we do know how to make a noise.
Charlotte.
Patient experience is, of course, really important, and if you're a person who works in the system, you see things through different eyes, and so your feedback is really important. And there are lots of organisations I know that encourage their staff to provide feedback, either directly or and encourage direct dialogue, but also online systems where if you want to remain anonymous, you can. But that feedback is really, really important. And I think in many, and I'm sorry that you had a poor experience, but I also know that often people have good experience. But unfortunately in healthcare, when we get it wrong, we usually get it terribly wrong. And there's never just one thing that went wrong. There's a series of incidents that all add up to something that's either been at least really annoying or at most fairly fatal or catastrophic for that patient. And so we need those feedback loops, and we need to develop ways of doing that, not just through surveys, because surveys are very high level, broad, but we need depth. We need patient stories. We need patients at trust boards talking about their experience. We need to use those experiences in feedback to create learning systems. And I think some places are getting better at that, but unfortunately, we still have a lot of work to do.
Don, do you want to talk briefly about this idea of system change? I mean, you spoke of your experience earlier when your son was being born, but I mean, do you think the system can disrupt itself from within?
Well, I want to be very careful. I do think that it is having patients with us would be better, but I totally believe we all have lived experiences. The last time I was in Qatar, my speech was about the care of my brother for 10 days in an intensive care unit, and I mean, it was an immensely instructive thing. I was trained as a doctor that the language that was used was don't lay your trip on the patient. If you had a bad morning, it doesn't matter. You still don't lay your trip on the patient. I think that's right. But I think you can lay your trip on the system. You can say, I was there, this happened, and I can help you change it. So I totally endorse that.
Gentleman there.
McGee, surgeon and past president of the Royal College of Surgeons in Ireland. In the recent New Yorker magazine, Atul Gawande wrote a lengthy, powerful, and ultimately very depressing article about the adverse consequences of the introduction of a very expensively designed electronic medical record in his Harvard group of hospitals. And I think many clinicians share the sentiments that he described there. He even describes the ludicrous situation where to overcome some of the deficiencies, we now have medical scribes or even virtual medical scribes. So the machines were introduced to help the doctor, and now to enable the doctor to interact with the machine, you hire another human being as well. So my question is, how did the designers get the electronic medical record very often so wrong, and what can be done to redress this or correct it? Thank you.
Can I respond to that? Yeah. So you have to understand the genesis of the electronic medical record in the US in particular, which was, it was never meant to serve the needs of the clinician, better decision-making, better viewability into the patient's record history and all that. It was really a glorified billing system to allow, in the US, the financial models, you get to bill, every patient represents a revenue encounter, and if you bill more accurately, you make more money. And that's actually what electronic medical records were originally designed for. And that's a mistake of intent. That's a mistake of the system design. Right? Much of the conversation that's going on, we're developing a value-based care model regionally in Central Texas, and that's why I'm there. It has a very different outcome in mind, which is what works better for the patient. And can you then design an electronic health record that promotes that, but also doesn't distract the physician? Right? We recently just launched a startup that uses voice recognition in the exam room to eliminate the need for the physician to actually record during the encounter. I think one of the views of technology which we have to remake, especially with regard to healthcare systems, is that technology will somehow replace the human relationship that happens in the room. It can aid it. We've had a panel discussion on AI, but I think we have to remain faithful to this idea that the interaction between the two humans is where most of the value transaction in healthcare happens. That we should actually use technology to remove as much of the impediment between that relationship as possible, and that we'll actually do better that way.
Yes, go on, Riley.
Yes, I think what you just said is very important, because we can't just scan everything. We cannot put, the health in cans and in boxes for people. It has to be, life. It has, to have, that heart, going on. So back, that's, the gentleman, when he talked about, the conflict of interest, I think there's conflict of interest with the insurance company, with the cost of the drugs and medications, with the cost that, we have in the hospital also for the electronic records. So I think that's where the design should go on. It's not just having a framework, just putting the information A, B, C. No, it is not a can, it is not a box. We have to free that. We have to bring life, outside the can and not inside. Because we cannot have, instead of designed, health, it will be canned health, and, we cannot accept that.
Charlotte.
My friend, I've forgotten your name, but I think you demonstrate how good humans are at finding workarounds. So, if the system doesn't work for us, we'll find a way around it. I think what we have to do in healthcare, particularly nurses, doctors, physios, pharmacists, etc., is engage with technology and become experts. Really engage and be technologists, be informatologists, and use that experience to help the designers make something that works for us. So taking something off the shelf will never work for a clinician, and it's a bit about ownership and being involved from the very start of the process. I don't think we have been very good at that in the past, getting better, but again, new skills, particularly for young nurses and doctors who come from a different world, they can engage with that much more easily than even I can. So I would encourage clinical people in particular to be much more engaged in the design process for technology to make sure that it helps us rather than hinders us.
Thank you very much indeed. The gentleman there, just to your right there.
But, with this debate between the technology and the human interaction, where is the balance? We tend not only in the hospitals to use more technology every day. What I'm noticing that with the young generation that are coming, who are using more technology and they are more prone into using the applications and the social media, the one of them will come to the room of the patient and immediately look to the x-ray without even saying, hi, what's your name? I'm Dr. So-and-so. So where is the balance? And when we speak more and more about using technology, what are we telling the younger generation of caregivers?
Who wants to, Dina?
So the basic answer is technology is here to aid the health organization, so to help them make decision and not to make decision on behalf of them. So even though we have AI systems nowadays, yes, it can give us accurate decision, but we should not eliminate the human factor. We should not eliminate the role of the doctor. So the role of the doctor should stay the same. The role of technology is to help doctors, is to help patients in terms of, if we have, for example, apps for lifestyle management that measure heart rates, that the continuous glucose monitor, and all these fancy devices out there, they are not there to make decision on behalf of the doctors or the patient. They are there to provide information that can help decision making. So that's the main point of view of the technology in healthcare.
Thank you very much. Excellent. Okay, I'm going to really press you guys to get through the questions because there's lots of hands sort of going up. There's two at the back there, and then we'll come to the front, and then we'll go over there.
So, hi, good afternoon. My name is Naila. I want to talk about, I'm a pharmacist, but my talk now will be from a patient point of view. So when we talk about the introduction of technology into the healthcare system, and as a small example, the generation of the electronic health records, I had an experiment about 6 years ago with a hospital for children. So they introduced this new system for electronic records. And what happened is that the doctors were not able, or they were not coping too much with the new system. So first of all, we ended waiting up for like 6 hours to just see the doctor. And my child that time was 1 year old with fever. And when we get in, the doctor was too much under work pressure that he had no time to communicate with us. Most of the time he was looking at the screen. And at the end, I couldn't get a diagnosis for my child case. And even he didn't care to look at me when he was talking. So he's telling me, Maybe it's a virus, maybe it's allergy, we don't know. So my question is, when you design a healthcare system or introduce a new thing, does the hospital management actually ask the doctors, the nurses, the people who are really in the floor, what are their needs to facilitate the communication or the service to the patient, or they just say it from their point of view as a business stakeholders? You know, because from my point of view, the two most important stakeholders are the patients and the healthcare providers. It's not the hospital management or the owner of the hospital or the clinic.
So the short answer to your question is, are the doctors and nurses and clinicians and patients asked? The short answer is no. And the last three questions have all sort of been tied together of once you have this technology in place, this electronic medical record system, what are the unintended consequences that are happening that sort of change that human interaction? And that it's, as Stacy pointed out, it wasn't designed. I would go as far to say the electronic medical record is not like even part of what we would call our human-centered health system. It's not. It wasn't designed to be part of the health system. It was designed to be part of the billing system. But because it's there, and because it's a very expensive and painful experience for the organizations to put it in, we're all trying to build on top of it. Since we have it, how do we provide care with it? How do we provide clinical decision support? And the unintended consequence is we now have all of the doctors, tapping away on their keyboards and sort of missing the moment that they have with their patients.
Yeah, I think this elevates the conversation to actually the design of systems. The conflict that the gentleman over here raised, that you reinforced in what you're describing, is actually a failure of design of the system first and foremost, right? Because the system is motivated to either make money or be efficient above the quality of care that's being provided between that provider and that patient. And so the system has to be revised. Here in the US, ours is woefully broken. The fee-for-service system is being currently remade with, payments that are more based on value and outcomes and things like that. It's almost ridiculous to say out loud in an international community because the US is so far behind the times in that way. But you actually have to consider the design of the system. What are the incentives that are driving that behavior? Those hospital administrators have dominion over those clinicians for a reason, and that reason is in the design of the system. And it was designed originally for for other reasons. It has been essentially perverted over time. But we actually have to ask the question, if you're going to consider the system as a whole, and if it's designable, then what are the incentives you're actually designing into the system?
Okay, very quickly, Charlotte.
I just want to say that I think the design is part of the issue, but I don't actually think it's the complete issue. I think that if we're going to provide person-centered care and care that is compassionate, then as professionals we have an obligation to work in partnership, in equal partnership with the person who's receiving care. And when people, and the issue is that the doctor was busy, and we know that engaging with patients in a person-centered way on a long shift is very, very giving of the individual in terms of their emotional ability to do that. And we need to provide support mechanisms for staff if we really want them to engage in person-centered conversations and not blame the technology.
Okay, gentleman there, and then we'll come to the front.
I am Francis Omaswa from Uganda. It's great conversation we are having now on the central role of the patient, of the community, of the population in determining their own health. This language also appears in various WHO documents and so on. However, I don't see any action that has been taken in the SDG classification of indicators, for example, to monitor this.
To monitor this?
To monitor we have indicators on UHC, on catastrophic expenditure, on the supply side of services, but none on people participation, patient participation. What should we do about that?
Go ahead.
That's an emerging field. In the model that we've developed in Central Texas, one of the first things we do, they call them patient-reported outcomes, but actually it's more like patient-defined outcomes. You ask the patient before they arrive, what is it you want to derive out of this episode of care? Someone may have some hip joint problems, right? And the medical establishment will measure your pain and your flexion and your return to mobility. The patient doesn't really care. The patient just wants to play, soccer or football with their grandchild, right? Part of the way to answer and part of the way to engage patients is actually ask them what they want out of their episode of care. It's just a matter of asking first and then actually tracking to that as one of the outcomes that the health system measures.
Don.
The vocabulary that's surfaced globally on what Dr. Ohmaso was referring to is what matters to you. Instead of focusing on what's the matter with you, focus on what matters to you. That's been taught here by Maureen Bisignano and Susan Edgerton-Levitan and others. I think it's a really great transition. I think to the patient-reported experience, patient-reported outcome measures, there's been great work at OECD on this, and OECD now has normative documents ready for ministries of health issued a year ago, January, which recommend at the national and subnational level the use of patient-reported experience and outcome metrics. It's still adolescent, but it's great progress.
Rueda, very quickly, another question.
I think it's very important to have, the political also support. We did not talk about that, but the commitment is very important, and we have to have, at least the minimum competences for the healthcare providers in this area, because, like you said, it's a new emerging area, but still we have darkness, in that area. I'm talking about an academic person. We have to have the education. We have to have the solid commitment of, the educators in this field. And also we have to have, like you said, we're talking not active participation, it's active engagement of patients and community.
I'm going to try and squeeze in two questions. Unfortunately, we won't have time. I'd love to go, but we've only got a few more minutes. Very quickly, and then another question there.
Thank you for having me. My name is Ali Younes from Al Jazeera English. My question is, I've listened to this fine discussion by the fine panelists, and I could see that there's a Western mindset toward approach to medicine and healthcare design and approach to community medicine. My question is, how do you go about channeling this healthcare design, and I see it's a fine approach to community medicine, to different cultures and across the world. The world is not just the U.S., obviously, as we know. Okay. And are there any also the lifestyle change in terms of population and the cultural differentiations has to go with the patient, but also the doctors. So that's it.
Who wants to have a go at that? Dina.
Just a small comment. I would disagree with you that this is the Western mindset. When it comes to design, you're involving the community, you're involving the culture. So we do projects here in Qatar with the health organization, in particular Hamad Hospital. We involve the community. So we do design with the community. So it is not really a Western mindset of thinking. It is, I would say, a global mindset of thinking. So that's my only comment.
This question here.
I'll just quickly say that definitely our conversation on the panel has been very Western, but the case studies that we document in the report are from around the world, including Africa, including Asia, and we intentionally tried to find examples of design and design thinking from a variety of a diversity of sources.
Okay. Question there.
Hi, I'm Peter Jones. I'm a professor at OCAD University in a Design for Health program, a master's program, and I was one of the contributors in the panel, but I did have, that is in the conversation leading up to the panel. And I'd like to ask a question about the designers of the future. So we're training designers now over the last 3 years for careers in design and healthcare, but where do you see the competencies? What do you see as the new designers in the next few years? Who should they be? What are their competencies? Where do they best fit in your organizations? I mean, we're talking about kind of contexts and concepts, but who are these designers and where do they fit? That's what my students want to know.
Very good question. Great.
I'll have a shot at that. I think the best designers are ones who are already participating in the health system. for the woman who's the pharmacist, for the other clinicians, you have a view into the dysfunction of the system that is richer than any outside designer could ever have. One of the things that we're doing as part of our medical school is actually training the physician leaders of tomorrow to actually understand and utilize design. They will be the ones best positioned to actually make the change. And if we give them the tools, then they will have the authority and the capability to actually make that change. So they're likely the ones that will have to deal with changes in service protocol, changes in technology, changes in care protocols. They're the ones best poised to understand both the change in the nature of medicine and the disease, and if we equip them with the capability to actually make that change organizationally and systematically, then we're more likely to succeed.
Charlotte, and then I'll go.
I agree. Healthcare professionals need to be leading and shaping design, but they can't do it alone. And I think that's why co-design is such an important word. We need people with different skills around the table to support them with different views and different mindsets, because you can't be expert in everything. But I certainly believe that we need much more teaching at undergraduate level around design and particularly technology, alongside the skill set and the principles to co-design correctly with patients and their families. And that, a lot of that is around teaching person-centered practice and how to engage with people in a meaningful way.
Don? Oh, sorry.
I'll just push back on one part of this. I agree with the conversation, but there are sciences here, human factors, industrial engineering, cybernetics, semiotics, signaling, and I think we need to build new intersections. I think there actually are disciplines that are embedded in design schools and engineering schools and bring them closer into healthcare. I think that's a frontier worth exploring.
Roya.
I think we started with more healthcare providers and patients at the table of the designers. I think now we have to end up with more designers at the tables of the healthcare and patients, because we have many commissions, for health. Like I said, the SDGs, everything. No one, from the designers, were there. So I think maybe this is one of the recommendations, even at the WHO, is to have, some kind of, experts from the design, part, in order to complement the global health agenda. If we want to attain, we have to have everybody there.
Okay, Yadina, go on.
So at Qatar, here at Hamad bin Khalifa University, we have a new program that is called Data Analytics for Health Information Management. In this program, it's more of a multidisciplinary research area. So people from design, from HCI, human factor, come hand in hand with people from AI, data analytics, and so it's more design is more of a merging different disciplines to satisfy one goal.
Great. And before we go, I mean, this is, aimed at policymakers as well. I mean, governments, this is really, really sort of critical. It's fantastic, but we want to, get the policymakers to digest this idea about the importance of design and putting people at the center of design. So in real layman's terms, very quickly, what do you want to see change? And what's the payoff for politicians? They've got to run for office in another 4 years' time. They want to be able to say, putting design at the center of it, we'll do this for our health system. What can it deliver?
Well, again, what's underlying our whole conversation today is the system is broken, and what we're all here to do is transform healthcare. And this conversation that we're having for the last hour is really about the title of the report is transforming healthcare into a human-centered health system. And so, I mean, I don't know how to run for office, but really to create a system that works for all of the different stakeholders, the patients, works for the doctors so that they have a workflow and a lifestyle that fits what they want to accomplish. For all of the different stakeholders, this kind of conversation is what's needed to make that difference.
Yeah, there was a reason this report was written for the policymakers, right? Because if you listen to the conversation we just had here over the last hour and a half, one of the fundamental issues we keep talking about is how the system is in pursuit of something other than a better outcome for patients. And so if the policyholders can digest this, then their opportunity is actually to design the system's incentives to actually prioritize that outcome rather than financial outcomes or anything else.
Dina.
So I think there is one take-home message as if when I started and as if everyone said that the main point is let's have it all human-centric. If it's human-centric, we will get the potential outcome we aim for. That's it.
Don, you've worked with politicians.
I have.
What about policymakers and design?
There's a lot of selling points here for the politicians. If you want costs to fall and quality to go up at the same time, give power to patients. It will work. We have evidence of that. And one of the ways to do that is to have design more reflect needs, just like my colleagues are saying. Costs will go down, not up, I guarantee it. And that's important. Second, you'll get votes because patients will be happier and not feel as helpless as we make people feel, and you can take credit for that. Third, the workforce should be happier. Tomorrow, you'll hear about Nursing Now and changing the conditions of nursing, but we have a serious problem politically in a workforce that no longer feels joyous about what they do, and we have gaps in coverage. The gaps are enormous. Don't you want to have designs that are far easier to work in as the people come to work every day to help
attract
patients?
people to it as well.
Absolutely. You get the support of a workforce that's large and important.
Ruwaida.
I think that, like I said, that we have many, presidents of the countries. They all actually committed to the SDGs and some other resolutions. I think we have to start from there, and we need also more policy briefs for them, and we need, to have a louder voice for the designer in the healthcare environment.
Thank you. Finally, Charlotte.
Our system has to transform. We can't keep doing things the way we've done because we all know our demographics are changing and it won't last into the future. So we have to do things differently. And I think it is important that we do it differently than we've done before. And the only way that I know that gets to a good outcome with everybody on board and is a win-win is through this process.
Okay, great. Well, I just want to say thank you and give a big round of applause to our panel, to Professor Charlotte McArdle, Professor Ruwaida Al-Maite, Dr. Donald Berwick, Dr. Dina Al-Thani, Stacey Chang, and of course, Aaron Sklan. Thank you very much indeed. Thank you.